Hello, and welcome to HIV.gov's coverage of AIDS 2020 Virtual. I'm Hillary Hoffman from the National Institutes of Health. In light of the current circumstances, the International AIDS Conference is being held in an entirely online format for the first time, and I'm pleased to be coming to you in this new remote format to share the latest highlights in HIV science. Joining me for this conversation is my colleague, Dr. Karl Diefenbach, Director of the Division of AIDS at NIH's National Institute of Allergy and Infectious Diseases. Karl, thanks for joining me.
It's a pleasure to be with you and all of you virtually.
All right, so Karl, today we heard an update on a clinical trial that's comparing long-acting injectable cabotegravir to daily oral Truvada for HIV prevention. Could you give us the background on this trial and briefly summarize the new information we learned today?
Sure, I'd be happy to. So this was a study which we called HPTN 083, and it was a double-blind, double-dummy study of injectable CAB-LA, long-acting, which I'll use as an abbreviation, and TDF-FTC as the comparator. So everybody got pills and shots. In addition, there was a drug lead-in period to the study where people took either took the cabotegravir pills as part of a lead-in, as part of looking at the safety of cabotegravir in the population. So that's a little bit of detail about the beginning of the study. Once the study began, participants received shots or pills, and both, every 8 weeks till they reached the end of the study, and then they went into a group called phase 3, where they were put on daily oral Truvada to cover the tail of the injectable cabotegravir, whether they were in the cabotegravir arm or receiving Truvada or TDF-FTC through the entire study. It's important to realize the study was done in the Americas and it was all in men. And the structure of the study was a non-inferiority design. So usually we think about is something better than, but in this case, there's a process called non-inferiority. Is it as good as, is cabotegravir as good as daily Truvada? So what we learned today, which is some additional details on just how good the cabotegravir is. When the study began, we received a word from the unblinded study statistician that we'd reached 25% of our endpoint. So there is a defined place in the trial where you take a break and you look at the data as the DSMB, the group that really is helping you evaluate the study. And they can see the two arms. The rest of us are blinded to the outcome.
Including the participants?
That's the double blind. They're
right.
Blinded, we're blinded. There's the DSMB is blind, is not blinded, and the unblinded study statistician knows. They know that there's an A and a B, and they're seeing the data divided by A and B. And they were able to look at this and say that it had reached non-inferiority at the time of the DSMB meeting. Mm-hmm. Subsequent to that, over the past 5 weeks, there was another data lock from that went back and picked up some additional endpoints. And in picking those endpoints up, they crossed the superiority margin, as it were. So they crossed over from non-inferiority and not quite superior into superiority. So any way you slice it, both of these are incredibly active. In the end, there were 13 infections seen in the cabotegravir arm and 39 infections seen in the Truvada arm, the TDF-FTC arm. So both of those were very significantly lower amounts of infection than you would see if we had actually done a placebo group. But we didn't because, again, we needed an active placebo because we have the standard of care of TDF-FTC. So that's the main thing that's new. We also have some additional data on when in the timing of the treatment the infections occurred. And we are waiting on some additional biochemical data, such as drug levels and on data related to drug resistance before the study is completely wrapped. Again, the labs are closed or have been closed because of coronavirus disease. And so now we're coming back and able to finish these things up.
Well, we'll look forward to hearing more.
It is really an exciting time. That we have done is the study has come to a point where people are now, as we can get injectable cabotegravir to the sites, participants are being offered cabotegravir or Truvada, depending on what they would like to use as part of their long-term follow-up. So people who were in each arm can pick one or the other. You don't have to switch. And that's important to realize, is the participants in some ways are rewarded by being able to get access to if they want to get access to the injectable cabotegravir at this point in time.
Right, great. And Carl, can you tell us a little bit about the population, like who was involved in the study?
Sure, that's really an important point because this was done in the Americas, and it was the study population was men who have sex with men and transgendered women. And it was mainly a very young population, a population that was heavily balanced with Latino and African Americans. So we really worked hard to make this study representative of the people at risk of acquiring HIV in the Americas.
Mm-hmm. And I think there were also some sites in Africa as well.
There were a couple. The vast majority of the sites were in North and South America, and I think there was a couple sites in Southern Africa, in Cape Town, for example, where there's an MSM population.
Mm-hmm. Great. So these are great results for men who have sex with men and transgender women, as you stated. But Carl, what about cisgender women?
So that is the main question that remains out there. And so at the time we started 083, we started a parallel study called HPTN 084 in cisgendered women, largely in Southern Africa. For a variety of reasons, the study started a little later. And then in 2000, as a result of the dolutegravir data that came out at the Amsterdam AIDS meeting a couple of years ago, we had to put the study on pause and go back and look at the level of birth control and contraception being applied to this population. So it slowed the study down. So we are in the process of seeking to complete the women's study. It is, again, a comparison of oral TDF-FTC versus CAB-LA in cisgendered women. And it's a superiority design. Is cabotegravir going to be superior to TDF-FTC? So we have, at the same meeting where the DSMB looked at 083 and stopped it for efficacy, they looked at the 084 data and said continue, because there's not as many endpoints yet. And so what we're doing is we're going to go from DSMB to DSMB and try to get the study completed.
Great. Well, we'll look forward to hearing the results from that, as well as the final data from HPTN 083 that you discussed. But in the meantime, what do these results mean for people living with HIV? Should people who are taking daily oral Truvada or Descovy for PrEP consider a switch to long-acting injectable?
So we have to keep in mind that this is not for people living with HIV. This is for people who wish to prevent acquisition of HIV. It is important, though, to realize that there's a formulation using CAB-LA and a non-nucleoside reverse transcriptase inhibitor that is an injectable for the purpose of treatment. So there are these things coming for treatment and prevention. I think that's a really exciting area of therapeutics research. I think for what this means for now is that we have some work to do to finish up the study, and then seek the drug company ViiV will seek approval for men and women and move their application forward. And what it ultimately means is we're acquiring different choices for people. What we have right now are pills that can be used daily or used in an episodic way. Eventually, we'll have this injectable approved. And then there are other medications on the horizon. Last year in Mexico City, we heard about the Merck compound that was put in a phase 1 as an implant, and it had good pharmacology. Development continues on that. But people are thinking about different choices that people can make and what fits best into a person's life. Is it a weekly pill? Is it a pill that is tied to your birth control, for example? So if you had oral contraception, there's at least one formulation being explored that is co-packaging oral contraception with TDF-FTC, for example. So in order to, that's a dual use, and that would be very important. We have implants, we have longer acting pills, and we have injectables coming. Not just for treatment, not just for prevention, but also for treatment. So this is an area with a very bright future. It's great to get through this study. I think the challenge that we face is once we have things that are so effective, how do you get the next one into approval? And I think it's going to, the community and the scientists are going to have to sit down and think about this and make some very careful plans for how we can work together so that we don't come up against a barrier caused by the need for a structure that requires a 30 or 40,000 person study that'll last 5 years, because nobody acquires HIV, which is the goal. So we should be able to come up with biomarkers or drug levels or some way of getting safety data and efficacy data without making it so this study is just so large that we can never do another one again. So that is, success leads to the need to continue to evolve, and that's where we're at right now in this field.
That's great. Well, lots of exciting options coming up. So to viewers who might be just joining us, I'm Hilary Hoffman from the National Institutes of Health. I'm here with my colleague, Dr. Karl Diefenbach, discussing the latest updates to come out of the AIDS 2020 virtual conference this week. Karl, another major piece of news we heard today was about the first potential case of long-term remission in the absence of a stem cell transplantation. This is the case of a Brazilian man, and could you tell us a little bit about this man?
So this, a short summary of the history of this individual is in October of 2012, they were diagnosed with HIV, and the numbers that are available through the abstract indicate that the person was probably at this point had been infected for a while, living with HIV for a while. And then sometime in December of 2012, the individual started on a drug regimen consisting of TDF-FTC with efavirenz. A couple of years later, this individual enrolled in a clinical trial, which was testing the idea, could you intensify therapy? And what you would do is add drugs hitting, medications hitting additional targets in the pathways. So you're truly maximally suppressing HIV with this multiple drug cocktail. And the cocktail that was added was 2 medications for 48 weeks, dolutegravir and maraviroc. Dolutegravir is an integrase inhibitor. Maraviroc has some interesting activities as a blocker of entry. It binds to the co-receptor CCR5. In addition, the trial that was done in Brazil added nicotinamide or the vitamin niacin to the regimen. Niacin has some biological properties as not necessarily being immunosuppressive, but modifying the immune response. So it's not quite so inflammatory and sort of smoothing things out. So the individual went on this regimen for 48 weeks, completed the regimen, and then had viral DNA measured in a variety of samples and had very, very low viral DNA. One thing I forgot to mention is that they mentioned, and so clearly the authors of the abstract think this is important, is that during the 48-week period where they were on the intensified regimen, there was evidence of viral blips. So that's a fact. Whether at the end that matters or not, history will tell us. So then the trial offered this individual a structured treatment interruption. Will you be willing to interrupt therapy and see how long it takes you to rebound? Well, we're now a little more than a year out from the beginning of that structured treatment interruption. There's been no evidence of viral rebound, no evidence of blips, and attempts to measure viral DNA in this individual have so far not been very successful at identifying the virus as DNA in the bloodstream. So it's an interesting single case. The current other two people that we've been tracking that have been quote unquote cured are Timothy Ray Brown and the London patient. And what's different about the two of them, Timothy and the London patient, is they were treated for cancers and needed myeloablation and then stem cell transplants. And therefore, they received a different method. So it would be what do we do next with this individual? It'd be very interesting to try to figure out whether there was something immunologically unique about the individual or something genetically about the individual that led to them being able to control and ultimately potentially eliminate their HIV. Because if you did get a genetic tip like that, you could then figure out how to maybe induce it in people via other means, like high levels of a given cytokine or chemokine could be exogenously applied to see if you could reproduce the finding. So because it's an N of 1, meaning there's only been one, it's to me very similar to the Mississippi child that Dr. Prasad and colleagues reported on several years ago, where this child appeared to have no virus in their system, and then at some point after a couple of years they rebounded. So again, it's still early days on this patient. We'll see how long, if and when this patient rebounds. But again, it's interesting. It's also important that we keep in mind that this is just a single patient. So as we think about what this means for providers and people living with HIV, it's just something that you stick in the back of your mind and think, oh, that was interesting. Let's see where this takes us. But I think it would be not a good idea for people to rush out and buy vitamins and start loading up on vitamins. We've seen what happens when people follow leads on that kind of a situation, like with hydroxychloroquine. We need to be smart about what drugs we take, and take ones that are prescribed by our doctors. So if you're well suppressed on a drug regimen, stick with it. Stick with your doctor's advice.
Sounds good. And Carl, how confident are you that the Brazilian man will manage to keep his HIV suppressed?
I have no way of knowing one way or the other. Based on past, like the Mississippi child was about 2 years. it's in some ways, we just don't know. And so that's why you have to keep an open mind and not dogmatically declare the individual cured, but rather that they are well suppressed at this point. But to understand whether it's a T cell response or an NK cell response, or there's some unique antibody or HLA-E or some other very interesting immunological parameter, let's figure it out. That's what science is about.
Right. So you mentioned the Mississippi baby, and there have been some other reports of children whose HIV went into remission after they stopped taking daily antiretroviral therapy. We've heard, very few reports of adult remission. This is the first potential one, in fact. So is there any reason why it would be easier to achieve remission in children than in adults?
Well, there's a couple of, everybody has their own set of reasons. And I think for kids, particularly newborns, they're at the time of birth is oftentimes when they first get exposed. So they don't have a very long time if they start there from the time the virus enters their body and their bloodstream to where they would start taking medicine. It could be as little as 72 to 96 hours. So 3 or 4 days, they start on medicine. That doesn't give the virus much of a head start. So there's that. For kids that start a little later, they also have a more immature immune system. So it is more malleable, more adaptable, better able to withstand insults than an adult that completely lacks a thymus. So there's also the dose of virus is coming from a source that is probably doesn't have too much variation in it, so that may help. So there's any number of reasons, but again, we don't know. And I'd like to point out that one of the other important things that occurred this year is dolutegravir was approved for down to very, very young children. So we are getting better at treating the youngest. And with that, the chances of seeing more of these children falling into remission is possible because the drugs are so much better. So the NIH remains committed to getting the best medications tested and approved for the youngest, so that we can all have full access, even the littlest people, up through the 80-year-olds can have access to the best medications.
Right. Yeah, it's so important to test drugs and prevention strategies in multiple populations.
Absolutely.
Right. Well, Carl, thank you so much for sharing these insights with us today. And thank you to our viewers for joining us. We appreciate your interest, and we'll be back at the same time tomorrow with further updates from AIDS 2020 Virtual. For more information, please visit hiv.gov.